Good afternoon, everyone. I'm Melanie Escher with the Arizona Telemedicine Program and the Southwest Telehealth Resource Center. Welcome to today's program. So as you entered your phone or your microphone, we're muted, but please use the chat function for questions and answers. It's down on the bottom of your screen. We also have a post-webinar evaluation. Please go ahead and fill that out. We are being recorded, and the recording will be posted later on our website to our archived event, our archive website. I'll be sending that in a thank you email to everyone, so you don't have to worry about writing that down right now, but after the program, I will send that information out to you. So in some of my emails I've already sent, we've got this continuing of medical education. There's CME credits for this. We've got our outcome objectives, the accreditation statement, relevant financial relationships, so on and so forth. The attendance tracking for CMEs can be found in the evaluation. And if you haven't set up your profile yet, I'll have information about that in the thank you email. And so for CMEs, you'll be able to get a transcript of your CME credits. And everybody is welcome to request a certificate of participation as well. Standard disclaimer, I don't need to read it out loud. And again, check our website for upcoming webinars. This will be in my thank you email as well. And without any further ado here, we're going to go, remember your opinion is important. We take those evaluations seriously, and we get great ideas for future and upcoming webinars and educational events. All right, so today we have Dr. Sarah Gibson. She's a psychiatrist, and she's the medical director of telemedicine of Blue Cross Blue Shield of Arizona Health Choice, and she is based out of Flagstaff. She's got some great stories to tell and share, and a lot of information will be coming forward. So I'm going to go ahead and stop sharing while she gets her screen up.
Okay, let's see. What do I have?
Dr. Gibson has been with us for a long time, and she's been presenting on telepsychiatry. She's been doing telepsychiatry. So are we at 35 years yet, Dr. Gibson?
Not yet.
Not yet. Almost, though. More than 30.
Let's see. When my son, we're at 30. We're
30,
at 30.
30 years.
Yep.
All right.
Yep.
All right. So without any further
who's
ado,
counting?
They're right. All right. So Dr. Gibson, again, welcome. And I'm handing the mic over to you.
And look, it changed my cameo on my picture. That's terrible. Well, welcome everybody to the world of telepsychiatry. I'm very pleased to be able to speak today because today is World Suicide Prevention Day. So Melanie pointed that out, and I think it's a wonderful opportunity to refocus this talk on this theme. September is Suicide Prevention Month, and today is actually the day of World Suicide Prevention Day. And so I would propose that we talk about telehealth, telemedicine, telepsychiatry through that lens. Because with telehealth, we have a history of a very robust history of effective healthcare provision over 30 years. And that's for all forms of telehealth, but telepsychiatry specifically, we've really done a lot of. And so I want us today to revision telemedicine as a means that we connect, a means that we connect with other human beings, and to also explore how we can elevate and empower the efficacy of us addressing society's mental health, number one, suicide, number two, and opioid epidemics. So we've got these epidemics going along. I'm sure you've heard of them. The suicide and opioid overdose epidemics especially are of concern to us because we're having many deaths. Now, the opioid overdose deaths that I'm talking about are not necessarily intentional, like a suicide. So those are definitely different categories. And then just a mental health epidemic that we're really struggling with, where people in our nation are identifying as being disconnected and struggling. So what I am proposing is that we have a proven efficacy modality, telehealth. And so let's take this as an opportunity to rise, to be curious about what we can do, and be creative about what we can do, and revision telemedicine as just one other means that we connect with other human beings. Professionals and providers in the mental health world need to be competent. They need to know what they're doing. They need to have all their licenses and knowledge and the things that they are expert at doing. They need to be competent. But in order to provide services, we also have to provide a connection. And this is where I believe that we can make a difference. There was a study that said that people who lack social connection had the equivalent in terms of epidemiology of smoking 15 cigarettes a day. And so again, here we are in these suicide and opioid epidemics. So if we're in a situation where we are physically distanced from other people, if we add in telehealth, it's an opportunity for a social connection. Why do I want to talk about this? Well, I've been doing this a while, a long time ago, 30 years to be exact, 29 years, I guess. We were called NARBA, Northern Arizona Regional Behavioral Health Authority. We were here in Flagstaff, and we were the northern 2/3 of the state, and we were charged with serving underserved shortage areas for mental health, psychiatry specifically. And this is a very vast area in northern Arizona, larger than New York plus New Jersey, but with only 11.6% of the Arizona population. And so we thought, oh, we've got a little shortage. This is also just a quick cameo to show you that mental health is a health professional shortage area. And this is actually 2023, but they publish these every year. And basically anything that is blue is a mental health professional shortage area. Well, that's pretty blue across the country. So we needed to figure something out. So with a great deal of courage and necessity, we just jumped right into this world of telemedicine. I was in Flagstaff at the time, as was NARBA, my agency that I worked for, and then we decided that I would start a clinic in Little Colorado Behavioral Health Center is what it's called. It's in Apache County. It's this purple county over here. And we had 2 sites, St. John's and Springerville. For me to get to Springerville and see patients, it would be a 3-hour, 20-minute drive. So if I were to drive out and back, that's a full day of work. So we decided to implement telemedicine. This little county doesn't have the population to support a full-time provider who lived on site. So this seemed like an ideal opportunity. And since then, most of what has happened in Apache County has been over telemedicine. And from that beginning in '96, we specifically started because we needed access to care. And we wanted to decrease inequalities and improve continuity of care. So that rather than saying, okay, well, we can't get a provider to you, so the patients would need to maybe drive to Tucson or Phoenix or Flagstaff, or a provider would drive out there but only go once a month or once every couple of months. So that continuity of care, we could provide services all the time. And then we've just continued with steady growth and a lot of excellence with top 10 telehealth programs in the country, a 10-year satisfaction study, presentations, publications, all the things, just kept building our base, building our base. And then we got surprised by this little thing called a public health emergency. The COVID-19 epidemic occurred, and we were able to really jump in and provide a rapid response for utilization and the needs. And also develop, we thought we knew everything, and also we had to develop a new paradigm of in-home services. And so now we're continuing with telehealth, and we are really focusing now. We've got this base, but we're really focusing on quality of care. And I'll talk some about that with innovation, with education, and with ongoing service delivery. So I'm going to talk about 4 areas in which we can look at success in this realm. So, of course, access to care. I mean, that's what this is all about. That's why telepsychiatry jumped right in on this, was to provide access to care. But we also needed it to be acceptable to both patients and providers. And we need it to be cost effective. And here's my passion is it needs to be a quality of care provision of services, not just stopping a gap. So here's another way to look at it. In terms of patient satisfaction, we published the first 10-year study with Dr. Krupinski, actually wrote it up for us, and she's a part of this program. We also have demonstrated cost savings with, especially with decreased travel, but also decreased hospitalizations, which are high cost things for mental health. And then we really were able to improve access to care. Number one, members can be treated in their own community, which is hugely important. If you have to take a day off work to drive your child to a centralized university system to see their child psychiatrist, you might not be able to do that. That might be a great, great burden. But to be able to see these people in their own community is very, very important. But it's also helped us with physician recruitment and retention. And we can also provide immediate emergency assessments. So if I were seeing a patient in St. John's and there was an emergency in Springerville, doesn't matter. I can just switch a telemedicine line and go to a different community. So we're able to provide psychiatric services to areas of physician shortage. And so I was able to go to multiple smaller need communities just by myself. Better team treatment, that was a surprise, but because we're able to connect multiple distant systems, places, clinicians, families, specialists, all in one hub, it can be amazing for team treatment. And I'll give you some examples of that in a bit. And then we're also able to care for people, not be driving. So we reduced geographical barriers, and that's why we think of rural and remote provision of care for telemedicine, but boy, that's the same thing in Phoenix. If somebody has to take 3 buses to get to their psychiatrist and it's 112 degrees, that's not safe. Cost efficiency, we were able to, like I said, reduce travel costs and hospitalizations, but also access specialists more cost efficiently. We're able to create centers of excellence. I love this. So culturally aware healthcare providers, for instance, on the people who are knowledgeable about autism spectrum disorders, they can be a center of excellence where other people can communicate in and hub into those, and then expanded specialist access. We've got the acceptance down. All patient satisfaction studies have been overwhelmingly positive. We did our first ever 10-year acceptance study. But also there were some surprises too. Like for instance, this was a great study that was fairly early on in 2008, where they looked at was seeing your psychiatrist over telemedicine acceptable in American Indians. And these were American Indian Vietnam veterans. And they compared how they felt both face-to-face and over telehealth and found that telepsychiatry was very well received and comparable in terms of how comfortable they were, how satisfied, in terms of how culturally accepted they felt. And so this is all kind of old information. We're all pretty used to this by now. But what about the providers? Do the providers like doing this? This is another tribal-focused study where they found that 91% of the providers believed that telemedicine was a beneficial model for tribal populations. They found it was an excellent screening tool, but also saved time and money and improved accessibility. And so the providers were also satisfied. And it's an opportunity for, I love this term, cultural humility and value-based respect. And so this is part of the quality that we're always thinking about and that I want to keep bringing us back to as we're talking about Suicide Prevention Day today, is we need to be really respectful of people's values and their culture in terms of spirituality, in terms of how their family interacts with them, respect for elders, especially with our Native populations. There's a historical institutional distrust, but that's really true for so many, especially people with serious mental illness who've been in the system for a long time. Languages, translators, we can do all that over telemed. Community participation. I've had sessions where the school's in there, the probation officer's in there, the whole family's in there, and they're all over telemedicine. And assistive devices. This is so cool. Was relatively new during COVID. We discovered that one of my patients who was deaf, she would try to read my lips. We'd try headphones. We tried getting the American Sign Language. But once we figured out that we could just put the transcription right up there as we talked, it was a miracle. We almost cried. We were so excited. It was so fun. It worked really well. And then we have a whole new culture of rural cultural competence that's emerged because rural areas have barriers to culturally appropriate mental health care. And so you can think about some of these rural issues, and I'm not going to go into that now, but being culturally adapted can enhance the relevance and trustworthiness of telehealth interventions. And remember, we're talking here about access to care, but also acceptance. How accepted is this by the recipient of the service, but also the provider? And so here's some things that can really help with community involvement and the practitioner learning the cultural competence and safety of the members that they're serving. So culturally adapted telehealth interventions are essential to maximize engagement and effectiveness of suicide prevention efforts. The technology, that's not that important, right? So to improve acceptability, fit, and responsiveness of interventions, broaden your thinking and broaden who's eligible. So don't say, oh, the elderly, they don't want to do this. Yes, they do. They love it. Children, they're completely on board. And yes, to doing whatever we have to do to connect, even if it's telephonic or audio only. If that's all we have, then we just make it work. Cost, kind of a non-issue. It's usually fairly cost effective or cost neutral, mostly due to decreased hospitalizations. But also, there's a big concern on the Medicare level, CMS level, that availability of telehealth would increase accessibility in a negative way, meaning drive their costs up, which was hard for me to accept that anybody would care about that. But anyway, it actually might reduce overall Medicare spending in some of these studies. And you can go back and look at these if you want, but really it did not lead to an overall rise in costs. So then what can we do to improve our outcomes and our quality of care and decrease health inequalities? So Tara Sklar, she has the best, my favorite all-time quote. This was years ago. She said a couple of years ago, expertise, ability, and therapeutic alliance are more important than proximity. Oh, thank you. It was so well said. To get back to my original paradigm is that we need competence, we need connection, and that's how we get extraordinary outcomes. So, is it a quality of care practice? Yes. Telehealth is evidence-based for treatment, and it is a quality of care provision of services. And so here's some studies with Health and Human Services. There was no significant differences between the quality of care remotely and care delivered in person. And then telehealth reduced barriers like transportation and time constraints. Remember my 7 hours of driving? That was a big barrier. And then patients who attended remotely had an increase in appointment completion rates. Really look at that. The no-show rate for telemedicine is lower. People actually complete their appointments. And that is for, this was not specific to mental health. This was for all services. Now, in terms of telepsychiatry, we have just so many studies that show that telepsychiatry is equivalent to in-person. So we're not asking people to have a lesser service for an assessment, a psychiatric evaluation, to establish the right and proper diagnosis, a therapeutic alliance, treatment adherence, meaning when you come up with a treatment plan and say to a patient, I'm recommending that you take this medicine and you go to this therapist, that people actually follow through and do those things. And clinical outcomes. Do they feel better after doing this? Here was a study in 2023 that was a meta-analysis, a big study where they looked at a lot of studies and a lot of numbers, and they stated that telepsychiatry had a symptom improvement effect similar to face-to-face treatment. So people their symptoms got better. There was no difference with symptom improvement, and all-cause discontinuation, meaning people stopping their services, was not any different between face-to-face and telemedicine. Now, here's where I get really excited. Telehealth providers must have the same standard of care as seeing a patient in person. You're not just sitting there in your pajamas, not paying attention and providing substandard care. No, you're responsible for obtaining all the information that you need, no matter how you're going to do it, for instance, a medical decision. So if you need a physical exam, you figure out how you're going to do it. If you need blood pressure, lab work, weights, all those things, you have to do it. But also whatever you're doing, as with seeing a patient in person, it has to be clinically appropriate. It needs to be medically necessary. So it's the same thing. It's the same thing. All the same laws, all the same standards, all the same regulations, and all the same rules and quality performance measures still apply, with the addition of some more regulations with telemedicine. We can do hard things. So for example, if you need to document a physical examination, well, it's pretty easy in psychiatry because much of our physical examination is just visual and we can document it. And so here's some examples of things that we easily can and should be documenting when we're seeing our patient. We can do a very good Ames test. And an Ames test, if you don't know, is an abnormal involuntary movement scale. It's a neurological evaluation that we do for people who have been on antipsychotic medication. And it's looking at their mouth, their face, their extremities for physical movements and tremor. And so we need to be documenting that, and we can do that on telemedicine. A mental status exam is part of the psychiatric examination, and that is done easily on telemedicine. Here's a great article that is called the Telehealth 10, a guide for a patient-assisted virtual physical exam. We have extra documentation requirements for telemedicine on top of what other medical standards we have. Under Arizona statute, that means the law. It requires informed consent to be obtained prior to providing care via telehealth, unless it's an emergency. So we need written informed consent that the patient consented to this service modality. And then we also need to document how we provided it. If you did a service over telehealth, you need to say exactly how that was. Was it audio video, or was it just audio only? And then as I said before, is it medically necessary? Is this an appropriate medium for this service? And then if it is audio only, document it. But also we need to document due to various permutations of the law that it was the patient was either unable to achieve video, perhaps they're in an area where they don't have enough bandwidth, or that they refused video and they declined it and they only wanted to be seen over audio. The important point is that you're not doing it for the provider's convenience. And that's the problem with audio only. The other issue with audio only, I believe, is this whole issue of fraud, abuse, and diversion. And the big thing that always rises to the top is identity verification. So if you're on the phone with somebody, it's a lot more difficult to document that you're seeing the right patient for the right reasons and appropriately. So do document that you verified their identity. And all of the big high-profile investigations for fraud, it was more that the fraud was done by the provider and it was not because of telehealth. But I also really think that if we are really compulsive and accurate with identity verification, that a lot of this concern over telehealth would drop away. This is another really cool study. There was no increase in diversion. This is just this last year. There was no increase in diversion of controlled substance via telehealth versus in-person. Let me translate that. If you're prescribing Adderall to somebody, there's no increase of them selling that Adderall to somebody else over telehealth versus if you're seeing them in person and giving them that Adderall. Provider type, patient location. This is just evolving and expanding all the time, but it really has more to do with the payer, who's paying the bill. And so if it's a CMS or a federal patient, then they have certain rules. Your state will have certain rules. Whoever's paying for it will have certain rules. And then, of course, licensure if you're a licensed professional. So those are who defines who can be a provider. They also define where the patient can be. So if a patient is the payer, if they're self-pay, then there's far fewer rules about where they can be and what kind of provider, but you still have to think about your license and the other laws of the state. And patient location is very much broadening, all kinds of places that we're able to provide services, which is very fun. Oh, that I forgot to tell you, this is my favorite portrait of myself. This is a little guy who drew me. This was in the old days when my telehealth monitor was a huge TV on a big stand, and that's the camera on top. And there I am in the middle of the TV. So, then we were rocking and rolling and doing all the telehealth stuff and telepsychiatry, and I kind of thought I knew everything. And then suddenly we had this new event, which it was that the COVID epidemic happened and everybody went home. And so I had to develop a whole new paradigm in my mind, and then new standards and guidelines for what do we do when we see people in home. Again, think about identity verification. It's more important here because if they were going into the clinic, which is what they always did before, you have identity verification. They've given their driver's license. The staff knows them. That's all lined up for you. But if they're in the home, then you have to really think about making sure that those things are lined up. You can establish a provider-patient relationship via telehealth. That's actually a legal definition that's in Arizona statute. But you must have proof of identity. You only have to do that once. A staff or clinic can verify previous contact counts. Like I said, you could only have to do it once. Patients can show a picture ID. They can hold up their driver's license. A provider, me, can show their name badge. I didn't put mine on, but you can show your name badge. They want to know you're legit. If this session is audio, you can ask them to verify their date of birth, something like that. And then there's just this wonderful burgeoning biometrics for telehealth proof of identity that are out there, fingerprints and all kinds of things. So that's getting a lot better as we embrace that technology. But then another issue, especially in telemental health, is the patient needs to attest to privacy. So ask the patient, are you in a private, safe space? If they're driving, no. Stop, pull over. I'll see you in your car, sure, but you better not be driving. And as a matter of fact, a fair amount of my sessions were in home, but the patient would go sit in their car in the driveway so that they could have privacy and be in a safe space. And then you must know where the patient is during the session in case of emergency. So if it's in the medical record, then that's good. But if they're not at home, you need to know where they are, because 911 does not work remotely. I didn't know that for the first 20 years I did it. Scary. We have a new thing called E911. Here's this phone number, and then you can ask to be connected to the emergency services for this location. Or what I did is have the sheriff's number, like of the county that I was seeing the patient at, the direct line, because 911 doesn't work remotely. Patients, of course, can do 988. Patients can identify a support person. You need to know if there's a firearm in the home. This is specific to in-home. Have a safety plan in place ahead of time. And be aware. Now, we talk a lot about the digital divide, and I think you've got some other lectures that will be a little more comprehensive about that, but there are a lot of technological barriers to in-home treatment that I never had to deal with until later. But a patient may not have the equipment, like they might not have a smartphone or a tablet or a computer. They might not have internet, and that was very true in Apache County, or they might not know how to do it. So you might need to have a staff member go to their house and help them connect in. We actually provided tablets that were dropped off at the patient home that had a data plan on them so that they could connect in. And there's other programs out there. But this is so cool. This is lovely, is that we have certain patients, and I think specifically about children who are in DCS custody or in foster placements, and then also adults and children who are in residential treatment facilities or group homes. They're very vulnerable populations, and they move around a lot. And it used to be that every time they crossed the county line, they'd have to have a whole new treatment team. And that's especially for these vulnerable kids. They really need a consistent provider. So telemedicine can really bridge that gap. Here's more about identity verification. Same thing as I already said. So lessons learned from the COVID epidemic. Patients are generally quite appreciative of in-home care. And they really appreciated that. But some people would actively avoid video, and you would have a sense that they didn't want their privacy invaded or their home seen. Like if they have a really messy house, that's really valuable information, and they may be aware of that, or they might not be. If you can find a kind human to go and help them navigate the technology, that is lovely. And then providers report a greater insight into their members' lives when visiting. So, it was always fun for me to see, oh, look at that picture that's up behind your couch. That's beautiful. Or, oh, that's a little messy right there. And you really got a lot more insight. But you do have to get creative and find a way to get drug screens, labs, vitals, all those things. Because healthcare is care. Back to my original point. This is all about connection, social connection. It's just another way that we are trying to connect. A provider-patient relationship must be established for any medical service, and it can be achieved via interactive video audio, and that is in the law of Arizona, that it is okay. But if you have a relationship, but also good rapport, that leads to a therapeutic working alliance where you are working together as a team to help somebody, and that is improving patient outcomes. And telehealth is a great medium for this. So we just want to make our technology invisible. Patients will quickly adapt and quickly establish rapport with their teleprovider, but we want to minimize the technological interface. So you want to have as much of your face and your affect visible as you can. Don't be too crazy with the background. Have really good eye contact if possible. And that has a lot to do with your camera angle. Avoid picture-in-picture at patient end. Let me say that again, because it's really unnerving for people to see themselves. They don't like that. Or having another person present, especially if it's in the clinic, can really help to make that invisible. How else can we make connection? Well, if you're a patient, you want to feel seen and heard. And we know that connection improves outcomes, and that eye contact is one of the most effective ways that we communicate that connection, especially in mental health, especially when we're talking about vulnerable things like suicide prevention. So demonstrate listening to the end of the sentence. Make sure that they know that you're hearing them. And then again, minimize that technological interface. Here's some examples of getting a camera to be a direct gaze. So I've got my little eyeball camera, and it's directly above the patient view. So if my patient's sitting in here, it looks like I'm looking at them, even though, which I am, I'm looking at them, but really I'm looking at the camera is what's picking it up. So that mimics a good eye contact. You don't want to be too close, but you also don't want to be too far away or a little talking head way in the background, like in board meetings. And then set up your monitors. Set them up so that, you've got it all figured out. Well, okay, my patient's there, but then my electronic medical record's there. Then I've got the internet here, and then I've got, so all the things that you need to have up when you're seeing a patient, make sure that they're so set up that it can really minimize that interface. And then in this example, I've got my patient, who's not a patient, that was my nurse, Janet. She is sitting right below the camera, and here is my medical record, so that I'm actually looking at that and typing and looking at the patient and looking at the camera, and everything looks like we're doing good eye contact. This is not good eye contact. If you can get an eyeball camera, it's not that hard. And avoid the ear view, avoid the top of head and ceiling view, avoid the up the nose view, which I did not picture. And do a test call. Prepare your space. You want indirect lighting. You don't want glare. I had to take down artwork that had a glare behind me because it was just too annoying. Make sure that your doors and windows and blinds are closed and that the patient knows it. Here's an example of an ineffective background that we don't want. Check that there are no beds in your background. That is such a trigger. A trauma trigger is my pet peeve. No beds in the background. What is your patient seeing? This is an actual screenshot, just saying. You don't want them to see that. So make sure that you see what's in your view before the patient comes in. This is a great little top 10 ways your telehealth backdrop can improve patient care from Medscape. I thought that was kind of fun, and you can play with that if you want. And then again, we're back to the same thing. Know the location of your patient and make sure that they attest to privacy. Now, suicide prevention. What do we know about therapy? Well, it works, even audio only. In this example, they used telephone-based nurse-delivered interpersonal psychotherapy for postpartum depression, very high risk time in a woman's life is a postpartum depression. This is just audio. It was nurse delivered. It was interpersonal psychotherapy, and they found it was very effective, and it improved treatment access disparities. Like if you're postpartum and you're depressed, it's going to be really hard for you to get into the clinic. But if you can just answer the phone, that will improve outcomes. Another thing to consider that is brief cognitive behavioral therapy. This is just the kind of therapy that was studied, but it's something to really think about, that they've got a 41 to 60% reduction in suicide attempts at 1 year with BCBT. And it's a great first-line intervention for high-risk adults. How else do we know that teletherapy works? Well, here's one where they looked at psychological interventions for patients with anxiety and depression. And what they found that there was a comparable efficacy to face-to-face, but it also allowed patients to engage better and adhere to treatment, meaning show up to their appointments better. In this, here's again the brief cognitive behavioral therapy. It has robust evidence for effectiveness, feasibility, and acceptability. And to me, this is the biggest plus for virtual psychotherapy is decreased therapy disruption. So here's 110,000 patients, and they were more likely to return for additional psychotherapy after we shifted during COVID to virtual care. And this is really cool, and I'm not going to go into it, but if anybody wants in terms of time, but if anybody wants to talk about this, I love to talk about it. There is a psychodynamic advantage to having a session over telemedicine, telehealth versus in person, and basically it's because it decreases that flooding and that olfactory and the touch and all the things that happen when you're in the same room with somebody. So people actually might feel a little safer if they've had a trauma history or if they have a great deal of anxiety. So, opioid treatment. Telemedicine works really well for that. Retention is comparable. And when we're talking about opioid treatments, meaning treatment for people with substance use disorders like heroin, fentanyl, pills, opioid pills, the key is treatment retention. The longer people stay in treatment, the better they do. And in this study, people stayed in treatment and had reduced fatal overdose. Why do I care about that? This is for medically assisted therapy for opioid use disorder, because opioids kill people and they kill them quickly. And so this is the actual website from Arizona Department of Health Services. And in 2024, we had 4,000 opioid overdoses and 1,500 deaths. Those are not on purpose. Those are mostly accidental. We don't know the actual breakdown. The opioids are right on the top of the list, but look at this. If you haven't been around the block very long and don't know, this is a pencil. It's very sharp, but this little tiny pile of powder here on the very tip is a lethal dose of fentanyl. And the 7 out of 10 DEA tested pills with fentanyl were deadly. One pill, deadly. And here's how they sell it sometimes. Looks like a sweet tart. 95% of overdose deaths in Arizona children were fentanyl poisoning. So, medication-assisted treatment is really, really important to retain people in treatment for this very dangerous dependence. Therapies without MAT, they only stay in treatment 12%. And why telehealth? Because that helps with treatment disparities. And why else? This breaks my heart, is that they looked at 450 community outpatient mental health treatment facilities, including Arizona. Only a third of the clinics offered medications for opioid use disorder. And so telehealth is one way that we can really overcome those barriers to in-person care and improve outcomes, improve treatment resistance. So I won't go into my whole medication first lecture, but here we are again. Telehealth improves outcomes. Yes, we have to be competent. We, as a telehealth provider, we can be a proud professional in a community of practice, but also we can provide connection. We can increase trust and use this technology as a healing modality to strengthen and support our relationships with our patients. Chronic diseases, which most mental illnesses are a chronic disease, they really require a relationship of some kind. And connection, warmth, kindness, and warmth have been proven, very fluffy words, but they have been proven to improve medical outcomes and health span, meaning healthy life, not necessarily longevity. Here's some suicide actionable telehealth recommendations. I'm just going to throw those up there. You can look at them. We have a lot that's going on right at this moment in terms of medical education and teleeducation. We have Project ECHO telementoring programs for substance use disorder, trauma in children, social determinants of health. I don't know all the ECHOs in Arizona, but there's a ton of them. Access in Arizona State, you can just go to their telehealth service page, and they have they keep it updated, but they are very supportive of telemedicine. And just remember that we can do new things, we can do great things, we can innovate, we can connect, we can try to get regulatory support. We can make sure we're using verification, so we're mitigating fraud and abuse. We can improve our care. And the technology is to support healing, not a distraction. Actually, I like this. Telehealth is a home visit. Think of it that way, or a house call. So yeah, I've got some guidelines in the PowerPoints that you can resource, but I think would you like me to stop sharing, Melanie, or keep this up?
Well, you can keep those up with resources. It
Okay.
looks like we've got one question. Looks like we got a
Okay.
comment here in the chat. Mental health
Okay.
stigma, of course, is one of the major barriers to access
Mhm.
to psychiatric care, specifically in the rural medically underserved populations. How do you address the barrier in a culturally sensitive manner?
What a great question. What a great use of telehealth, especially for opioid use disorders. They don't want to go to the clinic and have their truck parked in the parking lot for all their neighbors to see. And mental health stigma is such a barrier, and that is a wonderful use of telehealth. That was a wonderful way it's a wonderful way to use in-home services. It's cherry picking off of it's just such a great way to minimize that stigma, but in a culturally sensitive manner. That's where that kind human comes into play. Somebody who can relate to, we often have in our system, we often have case managers who can visit the home, help them set up their video, who lives in their community, understands their values, understands their culture. Absolutely. Great way to approach telemedicine.
All right, and if we have any other questions for Dr. Gibson, go ahead and put them in the chat. Dr. Gibson's slides will be available on our website in the archive site. I will be sending that out to all of our participants. You will have access to that, and along with the recording of today's session. For the evaluation, we can only offer the CMEs if you are if you were present, and you will get that link. You'll see in the link to send in your phone number to track that attendance. Anyways, it doesn't look like we've got a thank you comment. Thank you very much.
You're
Yes.
welcome.
Dr. Gibson always has a plethora of information and resources. Again, those will all be available for you to check out. And if you have any questions, you can reach out to us, and we can get back in touch with Dr. Gibson and get those questions answered for you, or at least point you in the right direction where the resources will be. So she's got, of course, the telehealth resource centers. We are part of the
Ta-da!
Southwest Telehealth Resource Center. That's where we are, the third one down. We've got the TTAC, which is, of course, they check out unbiased views of the technology that's available. And then the consortium, which is all of us. We've got our service provider directory, and of course the previous webinar she's got in here as well, but I will send that in the thank you email. Patient experience toolkit. There's so many resources available that you're all welcome to view and take a look at. And if you have questions, reach out to us and we can help answer those questions. So without any other questions coming in, we got another thank you. Thank you for joining us today, and please be sure to look at our website and check out for upcoming webinars and sessions and educational events. And we're going to be in the process of planning for our 2026 schedule of webinars, so be sure to keep checking back. Sign up for our newsletters and you'll be able to get the latest information when we've got new events coming up, and you can do that from our website as well. All right, well, we're going to go ahead and give you 9 minutes back to your day. Thank you for joining us. And thank you, Dr. Gibson, and of course, Chris Martin, who's in our Phoenix office in the background. And we look forward to seeing you again at a future event. Thanks, everyone.